Welcome everyone again to another episode of the ideaXme show that profiles the humans behind the really big ideas that are shaping our world, inspiring the future creators, and for all those like great stories. I'm Ira Pastor, your life sciences ambassador along for the journey. So as frequent listeners of the show know, we spend a lot of time talking about the theme of healthy aging. And the reality that aging and related biologic changes associated with aging occur across all the body's cells, tissues, and organs. And these changes affect the structure and function of the body, including our teeth and gums. And as such, oral health is the focus of our show today. The underlying processes of biologic aging can dramatically affect oral health. And many of the changes that we've talked about on other shows, such as cells renewing at slower rates, tissues becoming less elastic, our immune system weakening, and so forth, can ultimately have a major impact in the oral cavity. Oral health problems in older adults can include untreated tooth decay, gum disease, tooth loss, oral cancer. There's a variety of exacerbated chronic diseases. I'm honored today to be joined by Dr. Mark Wolff, who is the Morton Amsterdam Dean and professor in the Division of Restorative Dentistry at the University of Pennsylvania School of Dental Medicine here in Philadelphia. With both a Doctor of Dental Surgery and a PhD in Oral Biology and Pathology, Dr. Wolff helps lead the school to develop policy, to set its research agenda, to design treatment community protocols that serve in need of a wide range of patient populations. Before joining Penn, Dr. Wolff was professor and chair of the Department of Cariology and Comprehensive Care, associate dean for predoctoral clinical education, and associate dean for development and alumni relations at NYU College of Dentistry, which is the largest dental education institute in the United States. At NYU, he designed, developed, and implemented an extensive curriculum and carries risk assessment, and also designed dental information systems to assist dental schools in monitoring the risk of the entire dental patient population. Dr. Wolff has completed numerous international research and oral health assessment programs, has been a lifelong advocate and dental provider for individuals with physical, intellectual, and developmental disabilities of all ages. Dr. Wolff has served as the principal or co-principal investigator on multiple benchtop and clinical research projects, investigating dental caries, novel remineralizing agents, dental erosion, periodontal disease, dental materials, and dental hypersensitivity. Dr. Wolff has published over 100 scientific papers, text chapters, edited multiple textbooks. He lectures worldwide. He's a frequent consultant to the industry and has been the principal or co-principal investigator in many industrial and NIH-funded research programs. Dr. Wolff, thank you for taking the time to come on the show today and talk to us for a little while.
Oh, I am just thrilled to be here and help bring some information to people about healthy aging.
Wonderful, wonderful. Really appreciate you taking the time. Typically at the beginning of the show, we give our guests the floor just for a little while to talk about themselves. If you can talk about your background, where you grew up, but what interested you in the field of dental medicine, how you made the transition into academic research, and just a little bit of your journey towards the seat of dean here at the dental school at Penn.
Wow. So I started out, I grew up on Long Island, started out with the idea I wanted to be a dentist because I admired my dentist. Graduated dental school and did a residency in how to manage patients with medical issues, medical compromised issues. And I opened up a very conventional 3-chair dental practice on Eastern Long Island in Stony Brook. I started out volunteering as a faculty member there and practiced. I was working 40, 45 hours a week in my office. My practice always contained a significant percentage of my population being developmentally disabled that I was very comfortable treating. I treated a vast number of patients with issues associated with aging and the comorbidities and diseases, Parkinson's and dementia and things like that took place. And I was a full-time practitioner. I started teaching a half day a week and then a day a week and then a day and a half a week, and really increased my interest in research and always being the kid that asked why. I kept asking why, and eventually met a PhD mentor who said, you have to go do some research into tooth decay and understand a little bit more about tooth decay. And the area of research that I entered was actually looking at saliva flow, and how saliva helps control tooth decay, which launched me into a giant area associated with aging, and that is associated with changes that take place when we start to lose saliva in the mouth, which could be from medications that we're on that result in dry mouth, or could be from autoimmune diseases like arthritis, Sjogren's syndrome, other conditions that damage the salivary glands and actually result in decrease in saliva flow. One of the things that we knew is that saliva controls and neutralizes the acid attack on teeth. So as we see decreases of saliva, we see more ravages of tooth decay associated with, we eat sugars, the bacteria that are normally there now start to grow, except there's nothing to neutralize that acid. And we wind up in a scenario of getting cavitation, holes in teeth. 10 years after I graduated dental school, 12 years after graduating dental school and before finishing my PhD, I became an acting chairman of a department of general dentistry at Stony Brook. I did that for 3 years and changed the curriculum of dentistry from what was very conventional, literally from the time of the early 1900s. We started doing smaller cavity preparations and destroying less teeth, and that became something that was important to us. I stepped down as chair of the department, finished my PhD, and returned to the school as a full-time faculty member and eventually associate dean at Stony Brook. 2005, I had the opportunity to head to New York University and be responsible for the largest department in the school, largest department in the largest school in the world, and recrafted a program that focused on how to prevent tooth decay as much as how to physically treat. So everybody's used to going to the dentist and having them drill the tooth and putting a restoration in, whether tooth colored or in the older times, an amalgam, a silver colored restoration. I concentrated on the disease, not the cause of the disease. How do we stop the next cavity? What's causing you to get the tooth decay? And how can we prevent this? Because if you don't prevent it, you just stay forever in this cycle of get new caries, get another restoration, get caries around the restoration, and off we go. During that time, I had the opportunity to launch electronic health records at NYU. And part of what we did is essentially remind the practitioner about good practices. How come you haven't seen this patient to do a fluoride treatment? Why haven't you prescribed a medication? Why haven't we done a counseling for tobacco cessation? Why haven't we start looking at the causes of disease? And we use the electronic health record in what we call intelligent decision support to push to the consumer, get the dentist to do the right thing for the consumer, because the dentist knows what it is. Sometimes we just need to be reminded to do that. And we made that part of the process in the electronic health record. I was at NYU for 13 years, reforming curriculum and doing a lot of things that became part of modern dental practice, like risk assessment for caries, for tobacco cessation, and things like that. And actually implemented them at the world's largest school. NYU was graduating nearly 8% of the nation's dentists, and that's that's a tremendous contribution.
Oh, yeah.
In 2018, I had the opportunity to move to University of Pennsylvania, one of the nation's leading dental schools, and take the seat of chairman of the department, and actually dean of the school. What am I saying? And actually lead the school, and help craft the next generation of dentists graduating from this venerable Ivy League school.
Mm-hmm.
And that was a giant step for me. And I have to say, I was met with enthusiasm by the faculty, students, and staff of the institution, and we've done some incredible things to this point.
Outstanding, outstanding. I appreciate that background, and it definitely leads into several of the things I wanted to talk about. Yeah, I had the opportunity before the show to sort of go into PubMed and pull down some of your papers. And you published on a lot of very interesting topics, and I wanted to start off. There was a sort of a review that you wrote recently in the Journal of Oral and Maxillofacial Surgery, entitled "The Graying of America: Considerations and Training Needs for Geriatric Patient Care," and you go into a bit about obviously the demographics that we're going to be coming up against in the coming decade or so, where we're going to have 20% of the population older than 65 years, and aside from of course the issues with the out-of-pocket costs, you write about how older adults tend to be more medically complex. They have many different diseases, and you also point out something interesting about how, although geriatric dentistry is something that it's taught, there's sort of less programs, I guess you mentioned, require it as a clinical rotation or such. And then you also write about something known as the Seattle Care Pathway, which you were involved in creating. Could you talk a little bit about some of these intricacies with regard to the older population, and then and what sort of what the Seattle Care Pathway is, and how you see sort of the future in getting more clinical education and rotations through the geriatric population?
So, Ira, you're incredible in the things you pulled out of the literature there, and how you went through it. I appreciate that quite a bit. And you pulled out the nuances of where we need to think about this.
Mm-hmm.
So first, if we look at the United States and say that in very short order, 20%, 1/5 of America will be what was once called senior citizen, geriatric aging. I hate the term geriatric. I hate the term, well, aging is just happening. That's a chronology.
Mm-hmm.
But what geriatric is, my grandparents were geriatric. No, that I never thought of myself as geriatric. So we have to think about what that actually means to us as we age, and we need to look for new metrics to define how people work. So I know 85 and 90-year-olds who go mountain climbing, scuba diving, active life, can outrun, can outjog, can out. They're in general quite healthy.
Mm-hmm.
And the question is, the fact that they're 70, 75, 80, 85, are they geriatric, or are they just aging? Okay, aging comes with, as you described, the cells, the elastic, things droop, things change in shape. Those are natural aging changes, but there's nothing about their intellect. There's very little about their activity and how they're doing that makes that happen. 60 million people are in this, will be in this over 65 age.
Mm-hmm.
And if we think that we need to make specialists in treating geriatric or this aged population,
Mm-hmm.
that's 1 in 5. We can't make enough dentists to physically do that.
Mm-hmm.
So one of my emphasis is that every dentist that graduates dental school has to be trained in managing 99% of the needs of this aging population. And rather than look at this as geriatric, as aging, as a chronology, I was part of the Seattle Pathways that actually talked about a slightly different index, dependence. independence versus dependence. We're born totally dependent on family to take care of us. And we become independent at some age. We hope our kids become independent before 40. But that's a story for a different discussion. Exactly. And a different type of independence. But we become independent sometime, typically in our teens. We still need guidance, but less of it. And then we go through life with consigliere and people guiding us, but we shop for ourselves, we travel for ourselves, we eat for ourselves, we make independent decisions, and in general, if taught, we can maintain optimal health. Mm-hmm. So we can be made a partner in this, and we can produce good health outcomes for ourselves. We are conscious and make decisions of right and wrong. Somebody can be 45 years of age, have a motorcycle accident, mm-hmm. and a spinal injury, and suddenly go from total independence, super wealthy, super independent, however we want. This has nothing, this spans economics. That person goes from being totally independent to literally in microseconds, totally dependent on somebody shopping, cleaning for them, feeding them, taking care of them. So this concept of where we are in the spectrum of life becomes a real question. So we can go to age 92. One of the deans that I followed that was many years before me, I met, he was 91 years old. He still had patients coming in. He was mm-hmm. still a periodontist. He was still active. He still had conversations that knocked you over in his memory of the literature. Independent, 91 years of age. When he passed away, they had to call his patients and cancel them. Was there anything geriatric about that person? And the answer is quickly, other than age, no. Many of us want to go to age 90, 95 and not wake up in the morning. And that's the end. And we spent our entire life independently. And though we may have some medical comorbidities, we may develop a diabetes, we may have hypertension, medicine has enabled us to live longer. 1960, life expectancy was less than 68 years of age. Mm-hmm. Today, we're pushing 80. In the United States, other countries have actually even done better. Right. That's an incredible step forward. So we can't use the chronology. We have to use the dependence. Are you able to drive on your own? Are you able to get, when somebody comes into me and says, I'm having trouble eating, my first thought isn't, are their teeth okay? I ask about food insecurity. Are we talking about you not being able to get the right foods, go shopping, take care of? No, I can't chew well. Okay, that's teeth. The other is part of the social dependence that I, as a dentist, have to think about and help the patient get better with. And that's so incredibly important in this concept. When we change from fixing teeth to managing dependence, mm-hmm. we're managing this differently. So we talk about aging in terms of dependence. The how much help do you need from the dentist, from a caregiver? Mm-hmm. Can you get the toothpaste yourself? Can you hold the toothbrush? It could be arthritis. We need to remake the toothbrush so that you can hold it. You may not be able to. And that's not a giant dependence. Mm-hmm. That's just the dentist recognizing what type of accommodation to make for you. So for me, I look at dental education and say we have to make sure every dentist recognizes that when a patient can't hold a pen, they can't hold a toothbrush. Mm-hmm. If they can't hold a pen, or if they have a Parkinsonian shake, are you really telling me I'm going to teach you how to floss between your teeth? Mm-hmm. So it's recognizing where the accommodations need to be made and how we can help the patient best remain independent. And as they become more dependent, get the caregiver in. Sure. Start teaching the caregiver how to deliver the best care for that individual. And you have to partner them. You can't ignore you can't ignore the patient who may be totally cognizant if it's a cognition issue, if it's Alzheimer's, if it's a growing intellectual senility that we need to manage. Well, that's a different story.
Sure.
Then we have to talk to caregivers, all of them, not just one, and make sure they understand that.
Mm-hmm.
So frequently, as I work on patients that have happily aging, but are not conscious of their oral health any longer.
Mm-hmm.
I've had patients that come in. One of the real striking routines was a patient broke their premolar on the upper right side. And I had a student recommending replacement with implants and crowns to restore the patient's smile. I said, have you spoken to the patient about it? And the patient looked at, the student looked at me and says, well, no, not before I speak to you. And I said, well, does it bother the patient? Is it interfering with their ability to talk, to chew, to function? When we spoke to the patient said, I'm missing a tooth. I didn't know it. It was never something in the aesthetic that bothered him. It does not hurt. It's fine. We need to find what the patient needs as accommodation. Now, what's interesting is the daughter comes in and says, you're not leaving that space on my dad.
Okay.
So sometimes we need to have the conversation with caregivers, with family. And there are times when we're unfortunately treating family, as long as we're not doing harm to patient, that's okay too. But we need to educate everybody in this. It's not an easy picture.
Another topic that you've written about, we've discussed a few times on previous episodes, is that of the microbiome. This mix of 100 trillion or so bacteria and fungi and viruses and so forth that live on, in, or among our bodies. We normally think of the gut microbiome, but obviously there's a very major oral microbiome. You wrote this really interesting article in the Journal of Childhood Obesity called Associations of the Oral Microbiota with Obesity in Menarche and Inner City Girls. And you mentioned how alterations in the oral microbiome can be associated with obesity, which ultimately can hit certain hormonal changes and affect growth and development, a lot of inflammatory processes that can be mediated by bacteria and so forth. I know this is sort of the earlier stages of life, but we did a very interesting episode about a year ago talking about some potential connections between the oral microbiome and dementia potentially and so forth. Talk a little bit about some of what's going on in the microbiome space as it pertains to oral health and some of sort of the components of this that you're teaching at the universities nowadays.
So just as an aside, I'm not positive I'm the author on that paper. Okay. It is a Wolff on it. I'm familiar with the paper.
Okay.
I have
Still
to. What's that? It's
Okay.
a good paper. I know the paper.
Okay.
I'm almost positive that's not one of my papers. I'll have to check.
How many MS schools are there? All right, I'll check. Okay, but anyway, let's talk about the microbiome.
So that it's still a great question, Ira. And the microbiome has to be thought of as hundreds of different bacteria living inside the mouth in some equilibrium all the time. One of the things that's actually a giant challenge for us is what upsets the equilibrium.
Okay.
So we can talk about a lot of things. I already spoke a little bit about saliva helping to balance the acid. So saliva contains bicarbonate. It also contains amino acids like arginine, which can help supply bacteria that like to make base and feed them. We can stop brushing. Somebody who runs out and stops brushing for any reason, the bacteria get thicker. The microbiome switches to a more anaerobic and oxygen-deprived bacteria because it's thick and the bottom of the plaque is deprived of oxygen. It starts to secrete irritants that cause the body to react, and we see increases in inflammation. And abracadabra, a whole inflammatory cascade takes place, and that's very much where we think about intellectual, heart, Alzheimer's, all sorts of things that may have some inflammatory mediation involved in it, being exacerbated by oral health issues. So they talk about premature births, birth weight, heart disease. Now, that's not to say the opposite. By brushing your teeth, you can cure these diseases. This is another source of inflammatory mediators inside the body that may be correlated with seeing some of these diseases pop out along the way. And that's important for us to recognize. So this microbiome can be thought of as a balance. And any of many things. Eat a lot of sugar. Go off to college. We see kids that have never had tooth decay go off to college, gain the freshman 15. Where do you think the freshman 15 came from? It came from eating sugars and fermentable carbohydrates. Dang, they get tooth decay. So it's that transition that we see taking place that causes this same microbiome to go out of kilter. And that is what we see happening in the body. So if arthritis affects your ability to brush, if you become forgetful and don't take care of it, we see a shift in the biome that actually causes inflammation, causes bone loss. A whole load of immune mediators take place. Some of these bacteria that are in the mouth wind up getting caught in the coronary artery plaques. Okay, and none of this, like I said, brush your teeth, you may not be able to avoid heart disease, but I know having oral bacteria being involved in that is not a good thing. So it's important for us to be very conscious of this as we see oral health degrade. We see a lot of other things fall down at the same moment.
You've written quite a bit about what I'll refer to as the oral ecosystem of biofilms. You've talked about before sort of this three-way sort of eliminating plaque, fermentable carbohydrates, and of course fluoride, which has done amazing things for a long period of time. But then you make a point that dental caries, and I'm sorry to use this word in the COVID-19 era, but dental caries is still something of pandemic proportions. You mentioned, remineralizing agents, antimicrobials, things of this nature that have been placed in toothpaste and so forth. You've done some research, and as you mentioned, arginine is a way to alter pH. What are some of the next generation types things? Obviously, the non-confidential, the stuff that you can talk about. Where are we headed in terms of some of the niches that you think are going to be important in the coming decade or so with regard to new oral pharmacotherapeutic interventions?
So I think we're going to hear a lot more about microbiome balance.
Okay.
A few years ago, a lot of attention was being spent looking at, could we use probiotics or prebiotics to do this. The arginine that you're referring to, it is a prebiotic type nutrient. My PhD mentor used to talk about it as essentially providing good fertilizers to grow good things and encourage their development. We are the only species that brushes our teeth. We're one of the primary and essentially the only species that gets tooth decay.
It's interesting
because we also supply large amounts of something that wasn't native in our diet, and that's sugar in a refined sense. So eating a sweet pineapple has sugar in it, but you probably can't consume enough sugar from pineapple unless you do something to concentrate the sugar concentration, like suddenly make juices and and well defined items out of, you have to eat a lot of oranges to get as much sweetness out of it as you do drinking 8 ounces of orange juice.
Sure.
And the 8 ounces of orange, the 6 or 8 oranges that go into that, if you actually ate them, have a brushing quality, a change on, there's a mechanical, it's only when we decide to make it into a juice and drink it that these things start to become carcinogenic.
Mm-hmm.
When we concentrate and take sugar and go from sugar cane, and then we take all that sugar and make it into a refined sugar, put it into an 8-ounce glass of Coca-Cola or of energy drink, of anything. What we do there is we actually place those sugars in direct opposition, direct position to bacteria. Bacteria eat it, poop out acids, cause the tooth decay.
Mm-hmm. Mm-hmm.
So now they're looking at, can you change the bacteria and actually grow a better bacteria inside the mouth that puts less of the sugar-eating bacteria in there? We're looking at strategies that grow bacteria that produce less sugars, naturally grow them, and make that come about. There are antimicrobe concepts, go in there and kill, or specifically kill a major acid-generating bacteria. And through any of many ways, you can cause a lock and key that attacks a specific bacteria like strep mutans.
Mm-hmm.
We're working on trying to find those mediators for tooth decay and utilize them in a fashion that actually can help reduce, rebalance, bring equilibrium
Mm-hmm.
back to the mouth. And that's really a dramatic way of managing.
Excellent. Appreciate that. Moving from sort of the topic of healthy aging, you mentioned early on in your intro, you talked about some of the work that you have done, or patient populations that you've been involved in with regard to people with developmental disabilities, which is also a very unique, I guess, clinical dental niche. Can you talk just a little bit about how that evolved and sort of your experiences in that particular area? Because it's pretty fascinating.
So I'll give a shout out to the one person that actually changed my thought process on it, and that was one of my faculty as a student, a guy, Fred Ferguson. Fred thought that all dentists should know how to treat persons with disabilities.
Mm-hmm.
We're talking, this is 40 or more years ago now. And he taught us how to manage these patients without necessarily taking them to an operating room.
Okay.
Because operating rooms are what you use to treat an acute problem. You take somebody, put them to sleep, take out their appendix, fix a torn this, sew up a bleeding that. Whereas dental disease, tooth decay, calculus, tartar buildup on teeth, that's a chronic problem.
Mm-hmm. Mm-hmm.
We need to figure out how to manage patients with these chronic problems in a dental office, because you can't take somebody to an operating room every year to clean their teeth. It's too threatening to the physical health of the individual, because being put to sleep always comes with some risk. And it doesn't actually deal with the disease. So Fred got us into treating patients with disabilities, and I did a whole load of treatment on patients for literally, I started in 1982 and I left my practice when I went to Penn in 2018. And some of my patients had been with me for that 36 years. I treated them with high concentration fluorides frequently. I treated them along with my hygienist with frequent cleanings instead of waiting until it builds up. Get them early. I treated them with learning about their accommodation. So one of my favorite patients used to like pens. Every pen he came in, you would think that he was writing War and Peace. He wanted a new pen every time he came to visit us. First time I met him, I had to go sit in his car and just say hi to him. And when I realized he liked the pen, I gave him a pen. Eventually, I got to do an examination on him in the waiting room. And I sat with a flashlight and examined his teeth and gave him a pen and told him, next time you're going to come in. And next time we got him to just sit in a chair. He stood up, he sat down, he stood up, he sat down. We gave him a pen. And then eventually we tipped the chair back, and eventually, and we got so used to treating Michael that he was able to come in, sit down. He would meet people at the front desk and ask where his pen is. The pen was always coming on the way out. We would show him the pen. This is your new pen, Michael. Here it is. Put it down on the countertop, but you have to go get your teeth cleaned. And as long as we learned how to communicate and deal with him, we found the accommodation that made it possible for Michael, somebody with developmental disabilities as well as some other issues, we found the accommodation that made it possible to treat him. And it turns out it's the same thing throughout the aging spectrum.
Absolutely.
And that's why I kind of look at accommodation and disability dependence, the availability, as being the key to understanding how to treat. So I treated children at age 8, 9, 10 with developmental disabilities, and I treated them for 30 years.
Mm-hmm.
I think this is something every dentist needs to have the capability of. At Penn Dental Medicine, we're in the process of completing a center for persons with disabilities that will have as its center a suite for customized dental care. Mm-hmm. That will work to help train dentists, but more importantly, will work to get people care in a fashion that they can learn the accommodation, and it doesn't fit the typical profit model. It's because it's time consuming.
Sure.
It takes twice as long, whether we're talking about a person with aging and Alzheimer's, mm-hmm. or aging and Parkinson's. It may take me twice as long to treat that patient, sure. But I can figure out how to do that.
Before we get to our wrap-up question, there's one other thing I wanted to ask you about, because it was very recent. You published a paper called "Patient Aggression Towards Dental Students," and it highlights some really interesting numbers. That 86% of dental students report one instance of verbal aggression, 36% of one instance of reputational aggression, and 28% reporting one instance of physical aggression. I'm a pharmacist by undergraduate training. I've been shouted at across the pharmacy counter because the medicine was too expensive. But is this a major problem that's always? I never hit my dentist. Is this something that's more common?
But it's not uncommon for a patient to reach up and grab your hand.
Yeah.
Okay. And part of this is something that you've also seen my papers on. I work with a fairly substantial psychology team on fear,
right. Sure,
on the management of patients, and so when you look in the literature about ER doctors and the like, they have very similar numbers to what you saw in our papers. Yeah. About aggression. Okay. A good deal of this is, and I'm going to come back to the same discussion of accommodation. Mm-hmm. We need to understand why people are uncomfortable sitting in the dentist chair. I'm asking somebody to sit down and do something that they're just not comfortable with. Mm. And the less sensitive I am to your discomfort, mm-hmm. the more likely you react using visceral or actually, hormone, a testosterone type release, a fear, fight, or flight, sure. Epinephrine release. And I have to learn to manage that. I need to recognize in you when you're uncomfortable. Now, this isn't to say anybody went out and smacked the dentist in the face. That's not what we're talking about.
Okay.
But we are talking about patients who will push back against somebody, who will attempt not to allow somebody to and I mean, recognize dentists. There's nothing closer than somebody standing over the top of you with a drill and a mirror, while you're petrified of having something done.
Right.
So in many cases of people that either we haven't shown all the sensitivity to, or it pops out. And when you look at the dental student population, you're looking at neophytes who have to be, and what that said to me at NYU is we had to do a lot more training with our students to make them aware of the things. I have to see your eyes twitching slightly differently, dilating inappropriately. I have to see a bead of sweat on your brow, or when I shake your hand and say hello. In the days when we used to shake hands and say hello, now we bump elbows and all sorts of other things. But in those moments, I have to recognize you're nervous, you're uncomfortable, you're not feeling. We've just put in place in our health record at Penn, as a result of this, some questions about fear, asking you how fearful are you of your dental treatment. Has your dentist ever asked a question about how uncomfortable you are?
No.
We had studies, that same team, 17% of patients in pain don't see the dentist because they're afraid.
Wow.
We need to do things to make people feel more comfortable, is the truth.
Absolutely. Makes a lot of sense. Coming back to you, Dr. Wolff, we typically ask a question on the show as we wrap up about important influencers. Obviously, you've had an amazing career to date. You've no doubt met a wide range of important clinicians and researchers and so forth. Are there specific people that you may want to shout out to that really, you thinking back, if it wasn't for this person, Dr. Mark Wolff may be practicing neurology or cardiology or law or doing something totally different than where you are now?
I would be a fool not to highlight my parents, who gave me opportunity,
Sure.
who taught me to do good for people, who always stood up for that. My PhD mentor taught me a lot of different things, Israel Kleinberg, certainly about science and caring for it. Guys like I already shouted out, Fred taught me to look deeper at people and try and figure out how to make things work for them, and that was critical. My own dentist, who passed away before I graduated dental school, Dr. Zellman, I emulated being a dentist because I thought it was a great profession. Looking at it today, I would go back and be a dentist again. It's been a crazy ride. I never pictured myself sitting as a dean, but I got here and I got here trying to do good things for people in the community, good things for education of generations of dental students.
Well, this has been very eye-opening. It was a wonderful discussion, and really appreciating you taking the time to talk with us for a little while. For everybody that's going to be watching on the YouTube channel or listening on the various podcast networks, we've been spending time with Dr. Mark Wolff, Morton Amsterdam Dean and Professor of the Division of Restorative Dentistry, University of Pennsylvania School of Dental Medicine. Dr. Wolff, thank you for taking the time. Thank you for sharing your knowledge about all the critical components that we don't normally think about when we talk about oral health, but really is very integral from the earliest stages of our life to the later stages. Really eye-opening. And as we say on the show, thank you for moving the human story forward with everything you do, and now you're teaching and creating this new generation of practitioners. Really great hearing about everything, and really thanking you for taking the time today.
Oh, it's my pleasure, Ira. And I really believe you can't be healthy without having oral health. So we have to figure out how to get that to everybody in our community.